So let's have a look at spirometry, which is the way that we usually measure and calculate the lung volumes. So let's have a look at the apparatus first and how it's used. So someone breathes in through this pipe, and the air coming in goes through this tube where there's a CO2 absorber. So all the carbon dioxide is absorbed, and the rest of the gases like nitrogen and oxygen can go into this bell. Now this bell has a double-walled cylinder, and it's also immersed in water so it can bob freely up and down. And these are one-way valves, so they don't allow air to go backwards. Now this bell is attached to a pen, which is drawing on a drum that's rotating, a cylindrical drum. So when you breathe in, the oxygen and the other molecules all go into this bell, and then that increases the weight of the bell, and then the pen will go down because the thing is being weighed down. So expiration is when the pen draws a line down, and when you inspire, the air is being sucked out, so this thing gets lighter, and on inspiration the pen draws an upwards mark. And this calculates the lung volume and airflow with proportionality constant of the pen and the rotation of the speed of the drum. Now let's have a look at a spirometer trace. So this is something that you would get after you take the paper off the drum, which shows you the pattern of breathing of this person, and we can work out various volumes and tell different things about their lungs from this trace. So the capacity, when we talk about capacity, that's when the lung volume can be broken down into two or more smaller volumes, and then a volume is just one bit of air that is breathed in or out. And we've got to remember that the gases collected in this spirometer are different temperature from the body, so that can affect the pressure of the gas, and we'll get onto that later. But first let's look at what a typical spirometer trace for a young adult male who's breathed in and out of this apparatus would look like. So firstly, we have just normal breathing at rest. For a healthy young male, the tidal volume is the volume that would be breathed in and out at rest normally. And this is about 0.5 litres for a typical young adult male. So inspiration is going up and then expiration is going down, and that's the tidal volume. Now the expiratory reserve volume, the ERV, is about 1.2 litres, and you can see that this is when he exhales. So this is the amount of air which he can exhale, the volume of air which he can exhale past his normal tidal volume, which is about 1.2 litres, and this indicates lung integrity. So if this expiratory reserve volume is very small, then he might have a lung disease or something wrong with his lungs. Now the residual volume is the amount of air left after he expires fully. So he can't expire any more of this air left. So every time you think you empty your lungs completely, you're actually not. There's always some air left in it, which is about 1.2 litres. And the functional residual capacity is basically how much air is left after the tidal volume in the lungs. So it's about 2.4 litres. Now the inspiratory reserve volume, it's like the expiratory but the other way around, so it's about 3.1 litres, and this is how much he can inhale past his tidal volume. So if you take a deep breath and you inhale as much as possible, then you'll reach this peak here. And the inspiratory capacity includes the tidal volume and the inspiratory reserve volume. So it's this plus this, and it's about 3.6 litres. Now the vital capacity is from the peak to the trough, and it's basically if you breathe in as deeply as possible and you expire as hard as possible, how much air would be expired in that one expiration, which is about 5.5 to 6 litres, depending on how fit the person is and how capable their lungs are. So that's the vital capacity, and the total lung capacity is about 6 litres for a young adult male, and this is just everything added together, so all the volume that the lungs can hold. Now you'll notice that the residual volume and the functional residual capacity, we can't actually get these from spirometer experiments because obviously you can't breathe down to emptying your lungs. So it's not measured directly with spirometry, but with this thing called an indicator dilution technique, which exploits the conservation of mass and determines the residual volume and the functional residual capacity with a body plethysmograph. So don't really need to go into this in too much detail, but it's basically like displacing water. if you know that experiment. So now we're going to have a look at some equations. So standard temperature, pressure, dry. Standard means that we're at standard atmosphere pressure and temperature. So temperature is 0 degrees Celsius or 273 Kelvin. And to convert from to Celsius to Kelvin, you need to add 273. So for example, 25 degrees Celsius would be 298 Kelvin. And 1 atmosphere of pressure equals 760 millimeters of mercury equals 101 kilopascals. Just for unit clarity there. And those are the conditions of standard temperature, pressure, dry. And dry means no water, because water vapor affects the pressure. The pressure of the gas is in millimeters of mercury. The volume of the gas is in liters, and N is the number of moles of the gas. R is the gas constant, which is 62.3 millimeters of mercury times liters times per mole per Kelvin, and the temperature is in Kelvin. So water is an imperfect gas because it changes state, so from vapor to liquid, and it is special in terms of its bond formation. So things like ice is less dense than water, for example. So it's just got these odd little things about it that mean it's not a perfect gas within the physiological range of temperatures, and the perfect gas equation can only be applied after removal of water. Now, perfect gases over physiological temperature and range include oxygen, nitrogen, and carbon dioxide, which are the gases that we'll be looking at. Now, if we rearrange this equation, so PV equals nRT, this is a relationship between pressure, volume, and temperature. If we arrange this equation, then we get V equals nRT over P. So we can work out how much volume 1 mole of gas occupies. So at STPD, standard temperature pressure, 1 mole of a perfect gas occupies 22.4 litres, and we can work this out by this equation. So if we plug in the numbers, 1 mole of gas times the R, so 62.36, times the temperature, which we said was 273 Kelvin, divided by the pressure, standard pressure in millimeters of mercury, which is 760 atmospheric pressure, that comes out as 22.4. Now, the number of moles of the gas is not changed by altering the temperature and pressure of an ideal gas over physiological range. So you'll know that from chemistry, moles is just a quantity of molecules. So it's Avogadro's number, 6.02 times 10 to the 23. And that is not changed by altering the temperature. You can't make more moles of gas, of an ideal gas, by changing the temperature or pressure. Therefore, we can work out this equation, which is derived from this equation. So if we see that PV, if we move T to the other side, equals nR, PV over T equals nR. And this is the same for any gas. So if you have gas 1 and gas 2, then the pressure of gas 1 times the volume of gas 1 divided by the temperature of gas 1 will be equal to the pressure of gas 2 times volume of gas 2 divided by temperature of gas 2. Hopefully that makes sense. We're just rearranging this equation and working on the basis that the number of moles is not changed by altering the temperature and pressure. Let's have a look at a calculation, a sample calculation that we can do. So I won't scroll down too far. If you want to try this, then you can try that yourself, but now I will explain how to do it. So the question says, what is the new volume occupied by 1 mole of oxygen, warm to body temperature and saturated? So this is from standard, converting from standard temperature, pressure, dry to body temperature, pressure, saturated. And we can have a look at the equation we need to use. So this is the otherwise known as Charles' law, so the conservation of moles, because we're comparing two gases in different environments, and, well, one gas but converted into a different environment. And standard temperature, pressure, dry is 760 millimeters of mercury and 273 Kelvin. We know that 1 mole of gas occupies 22.4 litres at standard temperature, pressure, dry. Now, BTPS is 760 millimeters of mercury again. It's saturated with water vapor, but it's at high temperature, so 310 Kelvin. And if we wanted to dry it, then we would have to remove the 47 millimeters of mercury, so we'd get 713, but we're not looking at the dry temperature here. And now we just plug in the numbers. So we've got P1, the pressure of gas 1, which is in this environment, so STPD. We've got 760 is the pressure, and then 22.4 litres is the volume. The temperature is 273 Kelvin, equal to the volume of the oxygen when it's warmed and saturated. So the pressure is still the same, and then the volume is, we don't know that, and then the temperature is now 310 Kelvin. It's increased. So we've got this equation, and then if we rearrange it, we will get, so 760 times 22.4 times 310 divided by 273 times 760, cancel out those 760s. But anyway, if you do that on your calculator, you will get 25.44 litres is the new volume. Back to this, so what happens when we inspire 1 mole of oxygen? We've just demonstrated with that calculation that, firstly, if we warm the gas to 37 degrees or 310 Kelvin, which is body temperature, we will increase the volume to 25.44 litres. If we saturate the gas with water vapour, then we further increase the volume. So if we want to dry the gas, then we need to minus 47 to decrease the pressure of water vapour added. And we're working with the physiological conditions in the body. Now, partial pressure, this is an equation here, so the fraction of the mixture occupied by a certain gas times the total pressure exerted by the mixture. For example, if we want to look at the partial pressure of oxygen, nitrogen, and carbon dioxide, it's just the contribution of this gas to the pressure of all the gases, basically. So if we look at the partial pressure of oxygen, oxygen has about 20.9% in the atmosphere. The air we breathe is about 21% oxygen. So if we do this fraction times by the total pressure exerted by the atmosphere, which is 760, then we get 158.8 millimeters of mercury. Nitrogen, around 79.1% nitrogen in the air. It gives a partial pressure of 601.16, and partial pressure of carbon dioxide is about 0.04% times 760, which is 304 millimeters of mercury. There's minute quantities of noble gases and pollutants, which we don't really need to worry about here. So if we look at this chart, we can see that those numbers correspond roughly. So what do we work out here? So oxygen is 158, so 158 in oxygen. Nitrogen, I think I used different figures here, but anyway, I calculated nitrogen to be slightly higher here, but it's around 596-ish millimeters of mercury. That's the partial pressure, and this is 0.3. What happens to all the gases when we inspire it and use it in our bodies? So atmospheric air has this composition. We take it into the alveolus, and now it's changed composition. So the amount of nitrogen has decreased. The amount of oxygen has decreased because we're using up oxygen. We're taking it into the blood. And the amount of water vapour is obviously increased because it saturates. There's a lot of water vapour inside the body, which saturates the mixture of gases. And the carbon dioxide is increased because we are exchanging the oxygen for carbon dioxide, which is a waste gas. Now, these gases are in equilibrium with the arteries, so you'll see that the gases here are approximately the same as the composition in the arteries, and then as we go along the tissues and the capillaries, they all start to get used up. So nitrogen's the same, and water vapour is the same, but the oxygen starts to get used up, and the carbon dioxide starts to be produced. And then as we get into the veins, the total pressure in the veins, so if you add up all these numbers, it'll be less than this because it's reduced because the partial pressure of oxygen decreases more than the partial pressure of CO2 increases. So we are using up more oxygen than we are producing CO2, which makes sense. And then the veins, we've got a clear difference here. So the CO2 has increased and the oxygen has decreased from the arterial side. Now we're going back to get oxygenated at the lungs. And then the expired gas is just an extension of this, basically. So, yeah. And at sea level, resting normal partial pressure of oxygen in the alveoli is about 100. And partial pressure of CO2 in the alveoli, which is in equilibrium with the arteries, remember, is around 40 millimeters of mercury. Now let's have a look at the position of air in different parts of the body. So flow is proportional to the pressure gradient between the alveoli and the blood and the tissue. So the equilibrium is maintained from the alveolus to the arteries because of the flow. And as we saw, the atmosphere is about 79.03% nitrogen, about 21% oxygen, and very small amount of carbon dioxide, 0.04%. And that's probably an exaggeration there. So warming the air to 37 degrees at BTVS, we multiply it by 713 to find the partial pressure inside the body. Now, let's have a look at how the alveolar gas composition changes as we inspire and expire. So firstly, as we inspire, the carbon dioxide increases a very small amount, and the oxygen decreases a very small amount because of the dead space, which we'll talk about later. But basically, they're not increasing immediately. But after for the majority of inspiration, carbon dioxide will go down because we are taking in more oxygen, and the pressure is roughly maintained. So oxygen will go up, obviously, and this is the scale of oxygen, this is the scale of carbon dioxide. And then as we expire, the amount of oxygen decreases and the amount of carbon dioxide proportionally increases. It doesn't actually increase, but the proportion of it just increases. So we're looking at partial pressures here. Remember, that's the fraction times the total amount. So the composition of the air in the alveoli, as we've seen, so a lot of changes take place. Gas exchange takes place in the alveoli. So nitrogen goes down because some of the other gases go up. Oxygen goes down, obviously, because it's being used up. Carbon dioxide goes up, and then water vapor goes up. There's a lot of variations because breathing is intermittent, and the partial pressures don't reverse immediately at the beginning of inspiration, and the first gas drawn into the alveoli is dead space. And what is dead space? Dead space is where the air is not involved in gas exchange. So anatomic dead space plus alveolar dead space equals physiologic dead space. That's your total dead space in your entire airway, and it's made up of these two dead spaces. So the anatomic dead space is approximately equal to your total dead space. So there's most of the dead space is anatomic dead space. It's around 150 milliliters, and it's formed by the conducting segment of the respiratory tree. So things like your trachea and your lobar bronchi, those don't really exchange gas, so that's all anatomical dead space. Now, alveolar dead space is where gas should be theoretically, so it's in the respiratory zone, so it should theoretically be exchanged, but it's not, because the alveoli might not have enough blood flow, or some alveoli might be damaged or broken or anything like that. So this is any time the alveolar air doesn't participate in gas exchange. This is alveolar dead space. Your tidal volume is approximately 0.5 litres, 500 millilitres, and 500 times 12 breaths per minute equals 6 litres per minute. That's around how much you breathe in per minute, and only around 350 millilitres of this 500 millilitres reaches your alveoli. So the dead space is around 150 per breath. That means that the amount of air that actually reaches your alveoli is reduced. And we can have a look at the way we actually calculate that later. So, as a rule of thumb, the amount of dead space for a healthy individual is about 1 milliliter per pound of body weight, but that increases in disease. So, for example, a 170-pound person will have around 170 milliliters of dead space. The expired minute volume, so the total amount of air that you expire in 1 minute, is equal to the tidal volume, so the amount of air that you breathe in and breathe out at rest, times the breathing frequency, so the amount of times that you breathe during a minute, which makes sense. And because of a Western diet, the oxygen consumed is less than the carbon dioxide produced, and we'll have a look at why that is later because of the respiratory exchange ratio. Now, alveolar ventilation, so we said that not all air that we breathe in actually gets to the alveoli. Some air is stuck in the dead space, and around only 350 milliliters per breath reaches the alveoli. So how do we calculate that? Alveolar ventilation is the volume of fresh air actually reaching the alveoli, and the VA, or the alveolar ventilation, equals the tidal volume minus the dead space times the breathing frequency. Now, the breathing depth is more effective at increasing the alveolar ventilation than increasing frequency because of the dead space being constant. So if you're not ventilating properly, then increasing the depth of your breathing is going to be more effective than taking shallow breaths. We can have a look at how this is demonstrated here. So if this person has a tidal volume of 150 milliliters, and they have a lot of breaths, so 40 breaths per minute, then their minute ventilation will be 6,000, but their dead space will also be 6,000, so they're getting no alveolar ventilation, which is not very useful. If we increase the tidal volume but decrease the frequency of the breaths to keep the same minute ventilation, we decrease the amount of dead space, the total amount of dead space, so we get a larger alveolar ventilation. And if we increase the tidal volume greatly but decrease the amount of breaths, then to maintain a minute ventilation of 6,000, then the dead space decreases as well, the total dead space, so we get a much larger alveolar ventilation, which demonstrates this principle. And how do we measure alveolar ventilation? So we can't really measure the dead space that well. So the way we do it is using the volume of expired CO2, this equation. So volume of expired CO2 equals the alveolar ventilation times FaCO2, which is the fractional concentration of carbon dioxide in alveolar gas. And if you just stop and think about what that means for a second, it makes sense because the amount, so we'll get rid of all the units, no volume, nothing, just the amount of carbon dioxide that you breathe out will be equal to the amount of fresh air that's reaching your alveoli times the fractional concentration of the fraction of the amount of carbon dioxide that is in your alveoli. So that makes sense. And this works because all the expired carbon dioxide comes from your alveoli. But there's a problem because the volume of expired carbon dioxide is measured at standard temperature, pressure, dry. We can't measure it really inside the body, so we measure it coming out of the body. And the fractional concentration is STPD as well, whereas the minute ventilation will have to be in BTPS, the alveolar ventilation, sorry. So, because this is determined from spirometer measurements, these are in different units from this. And fractional concentration is determined from sampling and tidal volume as well, which contains pure alveolar gas. So we need to rearrange this equation or modify it in a way that we can use easily, and this is what that is. So the alveolar ventilation equation tells us that the alveolar ventilation in litres per minute is equal to the volume of expired carbon dioxide in millilitres per minute over the partial pressure of carbon dioxide in millimeters of mercury times K. And this K has units of millimeters of mercury times litres per millilitres, and it's a unit conversion from STPD to BTPS. Someone's already calculated this figure to be 0.865 millimeters of mercury litres per millilitres, and if you work out all the units, then it does cancel out to litres per minute. So yeah, so this equation is just a modified version of this equation, taking account into the differences in units and measurement conditions. So these units are the ones that we usually read them in, and it's easier to use the equation without converting too many units. So let's have a look at an example of a calculation using the alveolar ventilation equation. So you can try this by yourself if you want to, and I'm going to explain it now. So a control subject breathes at 12 breaths per minute with a tidal volume of 500 millilitres, dead space of 150 millilitres per breath, and expired volume of carbon dioxide of 195 millilitres per minute. What is the subject's alveolar ventilation and alveolar PCO2? So firstly, working out the alveolar ventilation, that's pretty easy. We can use this equation here. So we know the tidal volume is 500 millilitres, and we know dead space per breath is 150 millilitres, and the breathing frequency is 12 breaths per minute. So we just do this equation and we get 4,200 millilitres per minute in BTPS. Now to calculate the alveolar PCO2, we use this equation. So the alveolar ventilation equation got VA equals VCO2 times K over PaCO2, and we can rearrange this equation therefore to find out the partial pressure of alveolar CO2, and that is equal to VCO2 times K over VA. Now if we plug in the numbers, then PaCO2 is equal to VeCO2, which we know is 195, times this K, 0.865, divided by the VA, which we already calculated is to be 4.2 litres. Got to remember the litre conversion there. And that's equal to 40.1 millimeters of mercury. Now, PaCO2 is in equilibrium with CO2 in the arterial blood, so we come back to this diagram, and the carbon dioxide here is in equilibrium with the carbon dioxide here because the alveoli are exchanging gas with the blood in the arteries. So that means the alveolar gas equation defines the relationship between the alveolar ventilation and arterial partial pressure of carbon dioxide. That should say CO2, by the way, not O2. Now we can see that hyperventilation, so doubling the alveolar ventilation, so breathing twice as fast, halves your PaCO2, the partial pressure of carbon dioxide in your alveoli, because this equation says that this is inversely proportional to your VA. So hypoventilation, decreasing your breathing rate or depth, halving your VA doubles your PaCO2 because they're inversely proportional. And this graph here shows the relationship between PaCO2 and PaO2 as well. So if we plot alveolar ventilation in litres per minute with an O2 uptake of 3,000 millilitres per minute against alveolar partial pressure of oxygen or carbon dioxide in the arteries as well, that would be the same. So as we increase our alveolar ventilation, so as more fresh air reaches our alveoli, the partial pressure of oxygen in the alveoli will increase, and the partial pressure of carbon dioxide in the alveoli will decrease, and this is necessary because the total pressure can't exceed atmospheric pressure. So if partial pressure of oxygen increases, then partial pressure of carbon dioxide needs to decrease to accommodate for that. Now, normal alveolar ventilation is around 5 litres per minute, or 5 or 6, and the normal partial pressure of carbon dioxide, as we saw here, is around 40 millimeters of mercury, and of oxygen is around 100 millimeters of mercury in the alveoli. We can measure the partial pressure of carbon dioxide in the alveoli during anesthesia, and it's important to do this during surgery to monitor someone's ventilation. This can be done using an infrared analyzer. The monitor and tidal expiration of PCO2. For example, if the anesthesiologist discovers that the patient has a partial pressure of carbon dioxide of 80 millimeters of mercury in the alveoli, then that's double the normal figure, 40. And they know that they need to increase the alveolar ventilation in order to decrease this figure. And the partial pressure of carbon dioxide in the alveoli is only affected by the alveolar ventilation and the rate of expired CO2. So we've got to change one of those things, and they will change the VA. Now, VeCO2 and VA in exercise. So when we exercise, or if we have fever or hypothyroidism to a lesser extent, the volume of expired carbon dioxide will increase. So, for example, normal might be around 400, 200 or 400, and then when we exercise, we'll increase it to around 1,000 milliliters per minute of carbon dioxide that we expire. So we can see this inverse relationship, first of all, between partial pressure of carbon dioxide and alveolar ventilation. And the respiratory system tries to regulate the PaCO2 to keep at around 40 millimeters of mercury. So if we exercise and VeCO2 increases, then it will increase our alveolar ventilation to compensate for this. So that's how VaCO2 and VA affect each other, which we can see from this equation. So they are proportional to each other. If one increases by a certain amount, then the other will increase. So the body tries to keep homeostasis of PaCO2 near resting approximately 40 millimeters of mercury, even if the amount that we expire varies. So the respiratory exchange ratio, this is important for another equation. So firstly, what is it? Respiratory exchange ratio equation is the volume of carbon dioxide exhaled divided by the volume of oxygen used up, which is approximately 0.8. So that means that less carbon dioxide is exhaled than oxygen is used up. So it's typically less than 1 in a normal person. And if we're expiring carbohydrates only, then it's to do with the molecular structures of these compounds, so that would be 1 only. Whereas if we're using fats or proteins, then it would be slightly less than 1, so 0.7-ish for fats. Now, hyperventilation decreases partial pressure of carbon dioxide in the alveoli, as we know, and that has to increase the partial pressure of oxygen. However, we can't directly find out the increase in partial pressure of oxygen in the alveoli just from knowing an increase in alveolar ventilation, as we can with carbon dioxide, obviously, because of this equation. And this is, conceptually, it's just because the air we breathe in has a lot more oxygen in it than carbon dioxide. So what we do to find out the partial pressure of oxygen in the alveoli is use the alveolar gas equation. So this is made up of several things. So firstly, we look at the partial pressure of inspired oxygen, so the moist tracheal air, the partial pressure of the oxygen in that, minus the partial pressure of carbon dioxide in the alveoli, all times by the FiO2, which is a fractional concentration of oxygen in the inspired air, which is around 0.21, plus 1 minus FiO2 over R, which is the respiratory exchange ratio. So that's how we find it. An example question here, we can try this, and then I'll reveal the answer now. So example, in a normal resting individual breathing at sea level with a respiratory exchange ratio of 0.2, partial pressure of carbon dioxide of 40 millimeters of mercury, and PiO2, so partial pressure of inspired oxygen of 149 millimeters of mercury, what is their alveolar partial pressure of oxygen? So PaO2 equals PiO2 first, so PiO2 here is 149 minus the partial pressure of carbon dioxide, which is 40, and that seems normal, and then times the fraction of inspired oxygen, which is 0.21 at sea level, plus 1 minus 0.21, which is 0.79, divided by 0.82, their respiratory exchange ratio. And if we work that out, then that would be 102 millimeters of mercury.